So today we'll be discussing about urinary incontinence.
Okay.
If a patient comes with urinary incontinence, what are the types of urinary incontinence? How will you evaluate and how will you treat? So the symptoms, first based on the symptoms you characterize what kind of symptom a patient is having. So sometimes this kind of MCQs also comes. SBAs like which of these are symptoms of storage phase, which of these are symptoms of
Okay.
voiding phase and post voiding phase. So
Okay.
voiding phase you can remember with a mnemonic HIS, hesitancy, intermittency, slow stream.
Mm.
Voiding phase, there are only two: post micturition dribble and incomplete emptying.
Okay.
Are symptoms of storage phase. And this is also a question, although we will be studying in detail about urethral diverticulum, but
Okay.
any this SBA
Mm.
which uses this buzzword as post micturition dribble,
Okay.
your answer will be urethral diverticulum. So there are
Okay.
questions on we will
Okay.
be discussing what it is
Mm.
in subsequent classes, but for this buzzword is post micturition dribble.
Okay.
And storage phase symptoms, these include daytime frequency, nocturia, urgency, urinary incontinence, stress urinary incontinence, urgency, mixed urinary incontinence, nocturnal enuresis. So majority are storage phase. His
Okay.
is voiding phase
And
and post
intermittency
voiding
and slow stream. Okay.
triple and incomplete
And
emptying.
intermittency is intermittent. It's not continuous flow.
Yeah.
And slow stream is
This will anyways occur. Voiding phase is while the patient is voiding, right?
okay. Mm.
Hesitancy is she will not be able to void, there'll be hesitancy, it will come and then stop.
Okay.
Intermittency is also almost the same thing. Slow stream, it will come very slowly. So this is
Okay.
voiding phase. Okay. Even
Okay.
with just reading them also you'll understand, but just to remember during exam sometimes you get confused.
Okay.
This is how
Yeah.
you remember.
I get it, ma'am. But hesitancy is dependent on the patient's nature or some
Oh
issue
no,
with the bladder. Huh?
it is issue, it's avoiding dysfunction. It
Okay.
is not coming. It is due to sometimes the bladder gets it. It is a common symptom of this urinary tract infection. So
Okay.
it comes few drops and then it stops. Then it comes and then stops.
Okay.
So hesitancy and intermittency both are almost the same.
Okay. Okay.
Okay. Then types of incontinence. So there is overflow incontinence, stress incontinence, urge incontinence. Overflow is when
Mm,
there is blockage at the urethra. So
okay.
what happens? The blood, because of this blockage, the bladder is not able to empty, and when it is over full, it
Mm,
starts dribbling. That's overflow.
okay.
Stress is which when on cuff, it is when there is increased abdominal pressure
Mm,
or there is weakness of the supports,
okay.
the supports which support the bladder neck.
Mm,
So what happens whenever there is increase in the abdominal pressure, like if the patient's cough sneezes,
mm,
there is leakage of the urine. That is stress urinary
okay.
incontinence. Then urge is neurological. There
Mm,
is bladder oversensitivity due to
okay.
many causes. So it is mostly neurological.
Okay.
Okay. So most common type of these is stress urinary incontinence, then mixed, and then urge.
Okay.
So now how do you assess? First of all, you have to take the history. Based on the history, you will categorize.
Mm,
Then you need not do any investigation. You can initial treatment you can start without investigations only.
okay. Mm,
Okay. And in case it is mixed urinary incontinence, you uh, whatever the most prominent symptom is, you treat it accordingly.
okay.
And if there is stress urinary incontinence, for that first line we have, apart from the lifestyle changes and pelvic floor muscle training, surgeries are there. So
Okay.
before surgeries, uh,
Mm,
in case there is mixed urinary incontinence, then apart from giving these non-surgical options, you can also give medicines for overactive bladder. For overactive bladder, we'll be reading first line are medicine.
Okay.
Okay, so you can give both of them.
Okay.
Okay, so in a patients with urinary incontinence, you see whether how do you evaluate them? You see whether UTI symptoms are there. There is burning,
Okay.
increased frequency, urgency. In case there are these symptoms, then you are in all the cases you do dipstick.
Okay.
Okay, whether symptoms are there or not. In all the cases of urinary incontinence, you have to do a dipstick.
Okay.
In case urinary symptoms are present, then irrespective of the dipstick positive or negative, you have to do a culture.
Okay.
Okay, and if culture is positive, you start antibiotics. If culture is negative, you can consider giving antibiotics because she has UTI symptoms.
Symptoms.
Okay,
Though lipstick is negative.
though dipstick is negative and culture is also negative.
Oh, when both are negative, when okay, she is suffering from symptoms, we can consider antibiotics. Okay,
Yes.
but it's not mandatory.
Yeah. And if UTI symptoms are absent, again you'll be doing dipstick. If dipstick is positive, then only you'll do culture, and based on the culture you give antibiotics. If no symptoms and dipstick is also negative, then you need not do the culture.
Okay. And okay, no need of antibiotics also. So whenever the dipstick is positive, we are going for culture.
Yeah.
If it is negative, here in this scenario, even if the dipstick is negative,
If patients
oh
has
no,
urinary tract infection symptoms, then you can
we are
start.
giving only antibiotics but not sending for culture.
No, you are sending for culture also.
But
Culture comes out to be negative, still you consider because
if
it's
the
having
urine dipstick is negative, we are not sending for culture.
where.
In the second one,
Second one, she doesn't have symptoms also. UTI symptoms are also absent.
no,
So
ma'am. First one is urine dipstick is positive. We are sending for culture.
and you give
We
antibiotics.
are giving antibiotics, and in the second one, urine dipstick is negative.
You send for culture. Culture,
Oh,
suppose culture comes out to be negative, but since she
oh,
has
yeah,
symptoms to
sending for
infection, you
culture. Okay,
consider.
okay,
And
okay.
in
Yeah,
all
got.
cases, you are sending for culture, except for if there are no UTI symptoms and dipstick is also negative.
Okay, okay, okay.
Then
Okay.
you ask the patient about to this record a bladder diary. Okay, so bladder diary, how to interpret a bladder diary, this I'll be telling you. You have to always check the name, age, NHS number, and it is ideally advised for at least 3 days, and both day and night should be included. Okay,
Okay.
and the values that you have to remember: normal voided volume should be more than 150 ml. In case the patient is voiding more frequently, if there is small frequent voids, it is indicator of Detrusor overactivity.
Okay.
And daytime void, in if a patient is less than 60 years, it should be only once. If it is more than 60 years, maximum twice. Okay, this is night
Night
time.
time.
Yeah,
Okay.
daytime is 4 to 8 times, and if it is more than 8 times, it is abnormal.
Okay.
Polyuria, if there is more than 40 ml per kg in 24 hours.
Okay.
Normal fluid intake is 1.5 to 2 liters, and normal output is 800 ml to 2 liters.
Normal fluid intake is 1 point. Okay, this we are instructing them.
Yeah, this is average intake for everybody. Like,
Okay.
okay. So this is how a bladder diary looks like. How will you interpret if the patient comes with this? So you see here, this is 2 a.m., 7 a.m., 8 p.m., 8 a.m., 9 a.m., like this. So
Okay.
she's voiding multiple times. So
Okay.
if you count in the daytime from 7 a.m., if you include 1, 2, 3, 4, 5, 6, 7, and
Yes.
23, 8. So she's voiding frequently. Ideally, more than 8 is abnormal. Okay.
Okay.
Night time she's voiding only once, 2 a.m. she has woken up.
Okay.
Okay.
Okay. So until 11 o'clock, we are considering as day.
Hmm. Actually, it is until she is awake.
Yeah, okay. So bedtime, which should be
Hmm.
lesser than 60 years means once.
Huh.
Beyond, okay, more than 60, it can be twice.
Okay, but here the volume should be ideally more than 150 ml. So there are
Okay.
small, like
Yeah.
there are
Next,
frequent voiding and small
okay. Small frequent wines.
60 ml. So it is an indicator of Detrusor overactivity.
Okay.
This you are seeing here. This input is, if you total this, I totaled it for you. It is 1600 and output is
Okay.
1230 ml, which is normal. So input and output is normal.
So how much ml is this is input? What
How much
she has
she has
taken?
taken through the day
Okay.
and how much she's voided. So this
Okay.
is in the normal range. Okay.
Okay.
And then now, how many times she has felt urgency.
Okay.
So from 0 to 3 she has to rate. So 3 times she had urgency symptoms, and with urgency there is leakage also. So there
Okay.
is, this is called as urge incontinence, right? Reducer overactivity
Yeah.
with urge incontinence, because whenever she is feeling urgency there is leakage.
Okay. She's unable to control.
Yeah. So
Okay.
3 times this has happened, and also with the coughing, jogging, also there is leakage.
Okay.
Change. So that
Okay.
means it's a kind of mixed incontinence. This looks like a mixed
There
incontinence,
is
right?
stress continence as well as overactive bladder overactivity.
So it looks like this bladder diary looks like mixed incontinence, right?
Okay, yes, ma'am.
So this is how you interpret.
Here,
So,
stress incontinence is there. Okay,
hmm,
because leakage is there with the activities also.
yeah.
And so bladder, overactive bladder, we are making out from.
Overactive bladder because she's having urgency.
Okay.
So there is urge incontinence. With
Oh,
urgency, there is leakage also.
yeah.
And because on coughing, sneezing also there is leakage, so there is stress incontinence also.
So it is mixed.
Okay.
Okay, ma'am.
Then, then you assess for the residual urine, post-void residual urine. How do you assess? You can do it through a scan or catheterization. And ideally, it should be, if it is more than 100 ml, it is abnormal.
Okay.
And preferred is bladder scan because it is non-invasive.
Okay.
Then urodynamic testing. So what, how we do it? We have already studied in the last class. So when do we do it? Do we do it in all cases? The answer is no. So they give you this question like, what are the indication of doing urotype? Because it's again an invasive test, right?
Yeah.
The, those electrodes. So you do not do it on in all cases. So do not perform multi-channel channel filling and voiding cystometry before primary surgery if stress urinary incontinence or stress predominant mixed urinary incontinence is diagnosed. So then you can just treat for stress incontinence. You need not do it.
So
Okay.
whenever we are sure of this stress incontinence, we need not go for this urodynamic testing.
Yeah.
We
If
can
you're
directly treat it.
yes.
Only
And
when it is in doubtful cases, they are going for it.
yes. So indications, there are only 4 indications of doing urodynamic testing. You have to learn this by heart because there are questions which have been asked.
Okay.
So in case it is urge predominant, then you have to do or type of incontinence which is not clear.
Okay.
And if the symptoms are suggestive of voiding dysfunction.
Okay.
If there is associated prolapse also, because then you will be planning for surgery, right?
Okay.
So
Okay.
you have to be very sure what kind of incontinence it is, and in case there was a previous surgery for stress urinary incontinence. So these are
What is that anterior or apical prolapse? Bladder prolapse.
cystocele or this uterovaginal. Apical is if there is this uterovaginal prolapse.
Retrovaginal. Okay. And this multi-channel filling is what you taught last class, that euro
Makes sense, cystometry.
cystometry.
Yeah.
Okay. Okay.
Okay. And there is no role of doing this Q-tip, Boney's test, cystoscopy, imaging. All this are not. generally required. Then indications for referral to a specialist service in case there is persistent bladder or urethral pain, or if the bladder is palpable on bimanual or abdominal examination after voiding, if there are clinically benign pelvic masses, if there is associated fecal incontinence, neurological disease, voiding difficulty, fistula, previous continence surgery, previous cancer surgery, previous radiation. So anything addition to incontinence, if it is there, you have to refer to specialist services.
Okay.
Now this we have already studied. What is this?
Here, there is leakage.
Yeah.
Normal cystogram.
Normally there should be no leakage, no?
Oh, so there is leakage.
So how can it be normal?
There is no, but Detrusor activity is normal. So how should we say this? There is leakage.
So when there is increase in vesical or abdominal pressure, which happens like during cuffing, associated with it, there is leakage. So what it is, and there is no change in detrusor pressure.
So stress incontinence.
Yeah, this is stress incontinence.
Stress incontinence.
So there is change in P abdominal, P vesicle with leak. That is stress incontinence. Now, stress incontinence, how do you manage? So this is briefly about the management, and I'll be teaching you each one of these in detail in further slides. So first line would be you will ask them to modify their lifestyle, which will include they have to reduce caffeine in their diet, modify fluid intake. If the BMI is more than 30, they should be advised to lose weight.
Okay.
Constipation and cough, chronic cough, they will increase the abdominal pressure and will increase the symptoms of stress urinary incontinence. So in case that is there, you have to treat it.
Okay. So this is a modifying fluid intake. If they are taking more, we should ask them to reduce and vice versa.
Caffeine, fizzy drinks, they have to avoid.
Okay, ma'am. And how does caffeine affect?
Caffeine stimulates the bladder. No, it has a diuretic action.
Okay.
Yeah.
Okay, ma'am.
Then the first thing that you tell them after lifestyle modification is pelvic floor muscle training.
Okay.
And it is effective in 50 to 60% of the patients.
Okay.
So what they have to you have to digitally assess pelvic muscle contraction, like how strong it is. Sometimes in postmenopausal they start becoming weak, and that is the reason for this leakage. So you assess for the pelvic floor muscle, and you ask them for to do this pelvic floor muscle exercise. They have to do 8 contractions 3 times a day for 12 weeks. This you have to remember. For 3 months you have to tell them 8 contractions 3 times a day.
With a Phygel's exercise. Okay.
Yeah. And do not routinely advise electrical stimulation or biofeedback during pelvic floor muscle training. Okay. So you need not like there are these shock therapy, electrical stimulation, all that to contract the muscle. Electric current is given, so that all that is not required. Only you ask them to just manual by
Okay,
them.
they have to do by themselves.
Yeah.
And biofeedback is?
Biofeedback is like this. If they are doing it properly, you give them this positive reinforcement. All that is it's related to psychology. So you give them positive reinforcement. All that is not required.
Okay, okay. They have to just follow.
Yeah,
Take
they have to.
actions. Okay, thrice a day.
Okay. So in case first line would be this only. Suppose she has not improved. You have given a trial of PFMT for 3 months. You call them after 3 months if she has not improved. Okay. Then first you will refer them to MDT
Okay.
for deciding for surgery. Okay, then the option is surgery. Surgery has a 80% cure rate.
Okay.
Okay. So what are the options of the surgery we have? We have burst colposuspension, autologous facial sling, retropubic pelvic urethral mesh sling. So these are the three surgery. I'll be telling them what we do in all these.
Okay.
Okay.
And why are we referring to MDT, though we are sure about the diagnosis?
Because they are only doing the surgery, you know.
Okay.
Normal gynecologist will
All
not
those
doing
people
this.
have to. Okay.
Yeah. So they will be deciding for the surgery. Then after that, if the patient has not responded or refuses for surgery,
Okay.
okay, then other options are second line options will be medical. There is a medical option which is duloxetine. It is an SNRI.
Okay.
With this side effect is nausea and tremors, but it is less effective. It is only 50 to 60% effective.
Okay. And if suppose patient is not willing for surgery, second option is medical management.
You can either give duloxetine or you can give bulking agents. What are bulking agents? So what happens in this? There is weakness or loss of angle of the urethra. Okay, weakness of the muscle or loss of angle. So there are certain injections. These agents are injected into the submucosal tissue or urethra or bladder neck. Okay,
Okay.
so they will to just enhance the sphincter activity. Okay,
Okay. Okay.
it has a 60% success rate. So success rate for this also is less than surgery, and you
Okay.
need to give them repeated injections.
Okay.
Okay, and the last option is artificial sphincter. Okay, artificial sphincter is artificially. I'll just show you once what is artificial. So it looks like this device which is inserted. So there is a button which is attached to it. So when only when the patient presses this button,
Oh, okay.
urine will come out.
So
Okay,
it is
to
fixed
block the
inside
urine here,
the
it is like a artificially you are creating. Until then, urine will collect in this balloon.
it is fixed inside the scrotum.
Yeah, scrotum
How
in the
about
females it will be.
for
Yeah,
females?
females it will be in the this pelvis only.
Then where to press?
So there is a button which is
Which will be
externally
felt,
present.
which will
Yeah,
be palpable only
yeah.
for pressing. Okay. It will not get contaminated or what?
They probably change it.
Okay, like how they change valves.
Hmm.
And ma'am, this bulking injection, how often should it be injected?
It is based on the patient's symptoms.
Okay.
Okay. Then burst colposuspension. Burst colposuspension is we elevate the neck of the bladder and fix it with the ligaments of the body. Okay. So we
Okay.
elevate the bladder neck so that there is no leakage. So you put
Bladder
burst
is
sutures.
stretched.
Hmm?
Bladder is stretched.
Yeah, it is stretched. So it enhances sometimes because as I told you, SUI is because of the loss of the angle.
Oh, okay, okay, okay.
Okay, so it helps in maintaining the angle.
Okay.
So it corrects SUI and cystocele
Mm.
complications. Sometimes what happens, there can be urge incontinence or urgency can develop later on. There can be voiding difficulties, and since it just correct the cystocele, there can be chances of posterior compartment rectocele prolapse. So these are the complications.
Okay.
And you can do it either open or laparoscopic route. Laparoscopy, although operating time is longer, but there is lesser blood loss and quicker return to normal activities.
Okay.
Then there are sling procedures where again you support the bladder neck and urethra. So you can use normal like slings from our own body like rectus fascia, fascia lata, or porcine dermis, or cadaveric dermal grafts, or you can use these meshes, okay, tapes or mesh. But side effects are more in these tapes because these are external things. So there can be erosion or exposure, all that can occur. So nowadays they are not using these tapes.
Okay.
Okay, so how tight? If you have to put it only adequately tight, because if you put it too tight, there'll be voiding difficulty, and if it is too loose, there'll be persistence of incontinence. So
Okay.
only trained person should do it.
Okay.
Then retropubic mid-urethral slings. So when offering a retropubic mid-urethral mesh sling, advise the women that it is a permanent implant and complete removal might not be possible. Suppose there is exposure, so it becomes difficult to remove it. It can sometimes get infected. Then also it becomes difficult to remove. So nowadays they are not doing it. Meshes they are not using.
Okay.
Okay. If a retropubic mid-urethral mesh sling is inserted, give the women written information about the implant, including its name, manufacturer, date of insertion, and implanting surgeon name and contact details. And when planning a retropubic mid-urethral mesh sling procedure, the surgeon should use a device. This is asked in a question. So they ask you what is it this mesh made up of? It is made up of type 1 macroporous polypropylene mesh.
Okay.
So this was one of the SBA. It is type 1 macroporous polypropylene mesh, and the technique you need not go into details of the technique. It is just remember it is bottom up technique. This is
Okay.
also in one of the questions.
Okay.
Okay. Consider using a retropubic mid-urethral mesh sling which is colored for high visibility and for ease of insertion and revision surgery.
Okay.
It's a colored mesh made up of type 1 macropolis polypropylene material and bottom up techniques. Please
Bottom up technique.
the question.
Mm.
Okay. Then these are two types of surgeries. TVT, which is transvaginal tape, which we are putting from down. So it is like that. This is how it lifts up the bladder neck.
Okay.
And transobturator, through the obturator canal it goes, and it like maintains the angle of the urethra.
Okay.
Okay.
That's operative.
Hmm. But nowadays these tapes we are not using because of the complications. So details of the surgeries are not asked.
Okay.
Okay. Transvaginal tapes, more commonly it is associated with bladder injury, hematomas, and mesh erosion can occur. And transobturator tapes, although bladder injury, hematoma, voiding difficulty is less common, but it is more commonly associated with groin pain, thigh pain, vaginal injuries, and mesh erosion.
Solution. Okay.
Then, if you have done the surgery, when do you call the patient? Call patient back after PFMT. When were you calling the patient back?
After surgery.
No. After advising them pelvic floor muscle training, you ask them to come back
12
after how
weeks.
long?
12
After
weeks.
3 months, yeah.
Yeah.
And after surgery, you have to follow up after 6 months. Ask them to
Okay.
follow up for, after 6 months to check for like how whether there is recurrence or something. So this was about the management of stress urinary incontinence. Now coming over to if the patient develops stress urinary incontinence in the postpartum period. Okay, how will you manage? Because there was a question on this and a separate talk on it.
Okay.
Okay, so how will the patient present? The patient might present with urinary symptoms, and DDs in this case could be urinary tract infections. Stress urinary incontinence occur in 4% women after cesarean section, and urinary tract or the other DD is urinary tract injury, which occur in 1 in 1,000 cases. So if a patient comes with such symptoms, how do you manage? You have to remember that you don't do surgery in the postpartum period. You just observe because sometimes the symptoms resolve on their own.
Okay.
Okay. So if what you advise the women to try to complete their family before any incontinence surgery. So in
Okay.
case the patient wants to conceive, because again the symptoms can occur in the postpartum period. So you do these surgeries only after the patient has completed the family. That's one thing. Second, if a woman becomes pregnant after incontinence surgery, instead then you just and she has these symptoms again, then you just manage her conservatively. If a woman is continent after the previous incontinence surgery, cesarean section should be considered because
O-
vaginal delivery has higher chance of recurrence of the symptoms. Okay.
Okay.
However, if the continence procedure has not been successful, suppose it was not successful, if she is continent after the surgery, then you do cesarean section. If she already has incontinence, then to whether you do vaginal delivery or cesarean, it will not make any difference, right?
Vaginal delivery here plays a role. How? Because of the laxity of the perineal muscles.
Yeah, because of the injury and laxity of the perineal muscle. Okay,
If incontinence recurs or persists postpartum, avoid spontaneous recovery for at least, okay. So we are waiting.
for
So
6 months to
period
1
is
year.
up to 6 months or even 1 year.
Yeah, a,
Okay.
re-
Only then
a,
they are taking up for surgery. Mm.
a repeat mid-urethral sling procedure, if necessary, is most common, likely to be safe and effective. But nowadays, these meshes you are not using, you are using autologous slings.
Okay.
Using.
Slings can be used. Mm.
Yeah. So this was about postpartum SUI. Now, what is this?
Here there is overactivity of bladder with leakage.
Hmm. So,
Overactive bladder with leakage.
yeah, so this is detrusor overactivity with urge incontinence because there is change in P vesicle and P detrusor. And not all cases of detrusor overactivity will have a leak. So
Okay.
even if there was no leak, it will be detrusor overactivity only. Then how do you manage these patients? So here also again the first line would be lifestyle interventions. Lifestyle interventions would be you ask them to reduce caffeine, modify fluid intake, weight loss if the BMI is more than 30, and then you offer them bladder training. Okay,
Okay.
here PFMT will not help. Rather, you ask them bladder training. Bladder training is for like they have to go to the washroom again after every 1 hour, so
Mm.
that there is no leakage or urge. And if they are having the urge, they should control. Try to control for some time.
Okay. Mm.
Okay, so that is bladder training.
Mm.
So for 6 weeks, you ask them for bladder training. Okay.
Okay.
Then if after six weeks if it this has not worked, then
Mm.
you go for medications you give anticholinergics, oxybutynin, tolterodine, darifenacin or mirabegron. I'll be telling in detail in the future in the next slides.
Yes.
Okay,
Mm.
so these are the medications you give. In case patient is not responding to the medications, then you
Mm.
go for second line options. So before any invasive medications are not invasive, right? So before any invasive thing, you offer MDT. Okay,
Okay. Mm.
MDT has to be involved. Second line options are you give them botulinum toxin, which is inserted in the bladder wall, 100 units,
Mm.
or you can give them neuromodulation like percutaneous sacral nerve stimulation or posterior tibial nerve stimulation. And last is augmentation, cystoplasty or urinary diversion, which are the end. Like if she is not responding to anything, then only you go for surgery.
Augmentation cystoplasty.
Yeah,
What is it?
I'll be telling about it.
Okay. Mm.
Each of these in
And
detail.
here, like MDT, is, there is no role for surgery here. What, only medication.
These are the surgeries. No, all these are surgery only.
So these are surgeries. Okay.
Yeah,
Botulinum toxin. Okay. Invasive procedure. Okay.
yeah.
Mm.
Okay.
So, okay.
Okay, so medications now. First line medication is First, you give these non-selective anticholinergics, oxybutynin and tolterodine. Okay,
Okay.
so they are
Mm.
effective in 55 to 83% patient. And side effect, these anticholinergic side effects are there: dry mouth, constipation, blurred vision. So you
Okay.
tell them that although they'll be having these side effects,
Mm.
but if these side effects occur, that means these anticholinergics are working. Okay,
Yep.
but in case
Okay.
they are intolerable, you
Mm.
ask them to review back. Okay.
Like, okay. Mm.
Then if these are not tolerated, then the other first line option is you can give a transdermal oxybutynin transdermal patch is
Instead
also
of
available.
oral.
Yeah, if it
Okay.
is not tolerated because of these side effects. The problem with this transdermal patch is pruritus can occur at the site of
Okay.
application in 14% of the patients.
Okay.
Then second line option is derifenacin.
Okay.
Okay, so it is M3 receptor selective. These were non-selective, right? Now
Okay.
derifenacin is selective. It can also cause dry mouth constipation, but
Mm.
it doesn't have visual side effects.
Mm.
But it is also an anticholinergic. And third line is mirabegron, which is beta 3 adenoreceptor agonist. So it is not an anticholinergic. It it is a this sympathetic receptor agonist. So beta 3 agonist it is. It increases the bladder relaxation during storage phase of micturition. So that's how it helps.
So this first line and second line are anticholinergics.
Huh.
There is a darifenacin, there is no blood vision,
Hmm.
only mouth and constipation. And this is non-selective, whereas this is selective.
Yeah.
Selective means it is directly acting.
On the M3 receptors, which are there are M1, M2, M3 receptors. So
Okay.
M3 is present in all these. It is present in gut, sphincter of
Energy.
the urethra.
Okay.
Okay. So directly on those it will act.
Okay.
And mirabegron will not have all these dry mouth constipation because it is not anticholinergic. Rather, it will cause tachycardia and sometimes UTI. UTI because it increases bladder relaxation.
Okay.
So urine is there in the bladder for a long time. So
Mm.
there can be infection which can occur, right?
Okay. Mm.
So contraindication of giving mirabegron, you do not give if there is uncontrolled, severe uncontrolled hypertension.
Because
Because
it will lower the
it
severe
energetic
uncontrolled.
agonist, no, it will increase the BP, further increase the BP.
It will increase the BP.
Yeah,
How? Like it is causing bladder relaxation.
because beta 3 receptors are also present on the bladder, no, so it increases the
But
bladder
it will not
relaxation.
dilate the blood
Happens in
vessels.
incontinence is there is again and again a detrusor muscle is contracting. So this is relaxing the detrusor muscle. It will increase the bladder relaxation during storage phase.
Yeah, it is relaxing the bladder muscle.
Yeah.
How it's acting on the blood vessels then? It is constricting.
It is also acting on the blood vessels. It constrict because adrenergic receptors they cause vasoconstriction, right?
Okay. Okay, ma'am.
So that's why side effect of it is hypertension, tachycardia and hypertension, and in severe uncontrolled hypertension you do not give it.
Okay.
And contraindications to anticholinergic, that is OTD, which is oxybutynin, tolterodine, terifenacin. That's how you can remember. You do not give it in myasthenia gravis. You do not give in glaucoma, significant bladder outlet obstruction, severe ulcerative colitis, GI obstruction. So in all these cases, you do not give
All these three.
anticholinergics. So in any scenario where they give a patient who is uh, like who is 45 years with glaucoma, what is the drug of choice? Then it will be mirabegron. Or with myasthenia gravis, if they give you a scenario like that, then your answer will be mirabegron.
Okay.
In hypertensive patient, you do not give mirabegron. In those cases, the answer will be oxybutynin. So that when you will be doing the questions on this, no, you will understand how they
Yeah.
ask.
Okay.
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 Then, in case the patient has nocturia,
Mm.
then you give desmopressin.
Okay.
Okay, use of desmopressin may be considered specifically to reduce nocturia in women with urinary incontinence or overactive bladder who find it a troublesome symptom. But however, you have to use it with caution in elderly patients with cardiovascular disease or hypertension,
Okay.
okay, or cystic fibrosis. So in those cases, you have to use with caution. So you have to know in what all conditions you will not use them. Okay. So that's how the questions are framed on these questions. You
It
on
is,
these drugs. So
is,
you get a lot of questions on these drugs. While you will be doing the MCQs, no, you'll get to know
so,
how.
so
Right.
desmopressin is contraindicated in cystic fibrosis, cardiovascular
Elderly
disease,
patient, elderly
hypertension,
patient
and in
mostly.
elderly as
Yeah.
well.
Okay. Then once you have given the medicines, you ask them to review after 4 weeks. So after medicine, because it takes some time, you tell them that it takes some time for the medicines also to act. Okay. So they have to come back after 4 weeks. However, in case they have intolerable adverse effects because of these medications, they can come back before that.
Okay.
Otherwise, you call them after 4 weeks.
Okay.
After 4 weeks, you assess whether there is good response or no or suboptimal response.
Okay.
Okay, if there is good response, then you continue treatment, and then if the patient is less than 75 years, then you review them annually. If
Mm.
she is more than 75 years, then 6 monthly review. Okay.
Upfront review less than 65 years. Okay.
Okay,
Okay.
and it could be a face to face or telephonic review, anything.
Yeah.
So this is when the response is good. Suppose there is no or suboptimal response, then what you will do, you can try alternate medication and again review after 4 weeks,
Okay.
or you can refer to secondary care if they are not willing for any other medication.
Okay.
So it has been seen that overactive bladder doesn't respond to first line treatment in over 50% of the patients. So only 50% people will respond to these medications. Okay.
Mm. Okay.
So in those cases, you have to refer to secondary care, discuss with MDT, and do urodynamics. So in urge incontinence, I told you that you have to do urodynamics study.
So
After,
urodynamic study is not done in the as the initial assessment.
before, if the symptoms are looking like urge, you give drugs. If she's not responding to drugs,
Okay,
then
only
you
then we are going for the investigation.
yeah. So this is also important. They ask you what is the next step, and then they confuse. You'll give medicine. You'll do urodynamics. So you have to know
So
step by step how you
next
go.
step is medicine only.
Next step is first line would be first your lifestyle changes, bladder training,
Started training and then only medication.
since then urodynamics.
Okay.
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 Then these are the invasive procedures which you, and for any invasive procedure before that you have to refer to MDT and do urodynamics to
Okay.
confirm.
The secondary care consists of specialist people.
Yeah.
Okay.
Okay. Then what are these invasive procedure? Either it could be surgery, augmentation cystoplasty,
Mm.
or botulinum toxin A,
Mm.
or percutaneous posterior tibial nerve stimulation, or percutaneous sacral nerve stimulation, or urinary diversion. So we'll be discussing one by one what
Okay.
these are.
Mm.
Okay. So
Okay.
first is botulinum toxin A.
Mm.
Always you give it after MDT review. This though I've already told you. Okay.
Okay. Okay. Any invasive procedure. Mm.
Any invasive procedure. So what do you do in how do you give with cystoscopy under cystoscopy guidance, you in the bladder wall you inject.
Okay.
So these are the various patterns where how you can inject. You can do it under local anesthesia or general anesthesia. It takes around 20 to 30 minutes, and it
Okay.
is done under cystoscopic guidance.
Mm.
Uh, you do it with a flex. Best is you do it under local anesthesia with flexible cystoscope in outpatient setting.
Okay.
And mostly you give 10 units per site in 20 sites across the dome of the bladder. Okay.
10 units per site in 20 sites. Okay.
Across the dome of the bladder, and it is diluted in 0.9% saline to give 10 units per site. Okay, you 0.5 to 1 ml at each site.
Diluted in 0.9 ns to give 10 units per site injection.
You
Site
need not get into too much details of the
so
dose.
0.5
They
to
do
1
not
ml
ask,
is given
they
per.
do not ask this dose. They will ask the other one. This 100 units is important.
So
Okay.
maximum is 100 units or 100 units of botulinum toxin.
Yeah, so I'll be telling about that. This is the
Okay.
general regimen.
Yeah, okay.
This in detail they don't ask about all this.
Yeah,
Okay.
okay. Mm-mm.
Botulinum toxin injection is effective with long duration of action, but there are problems with it.
Mm.
Two important complications which you have to explain. There can be urinary retention and infection.
Okay,
Urinary retention occurs in 10% and infection occur in 20%. So in
okay,
urinary retention occurs, you have to teach them this clean intermittent self catheterization so that they can remove this
yeah,
remove the urine. Okay.
okay. Mm.
So you give botulinum toxin A. So in some questions they also give botulinum toxin B. So this is not useful for overactive bladder.
Only A, okay. Mm.
Only A. This also you have to remember. And
Okay,
you give 100 units bladder.
mm.
This 100 units you have to remember that previous dose is not that important. So the initial treatment is you give 100 units bladder wall injection, and
Mm.
in case the patient has develops these significant voiding dysfunction,
Mm.
then you teach them clean intermittent self catheterization. If the
Okay,
patient doesn't want to do that, then you can put a temporary indwelling catheter.
okay,
Okay. And then after botulinum toxin, when do you review them back? You review them back after 12 weeks. Okay, because it takes that much time for it to act. Okay.
okay.
Now
And
after
the
12,
next dose can be given after 3 months if they are fine.
yeah. So after 3 months, you see how you evaluate whether there is good symptom relief,
Mm.
inadequate symptom relief, or no effect.
Okay. Mm.
In case there is good symptom relief, then you just review the symptoms. You if there is good relief and she's asymptomatic, you do not give any further injection, and you tell them whenever they have another episode of similar symptoms, then you will be repeating it. Okay,
Okay.
you will repeat treatment only if it is necessary,
Okay. Mm.
because it is already relieved. Now what you will just wait for, in case it recurs, you give another injection. Okay. In case there is inadequate symptom relief,
Mm.
then you can give instead of 100, then you give 200 units,
Okay, we are increasing the dose.
and you review in 12 weeks
Okay.
again.
Okay.
Okay.
Mm.
And in case there is no effect, you discuss with the local MDT.
Okay.
Okay. So this is how you manage. You get questions on botulinum toxin A also.
Okay.
So they will give you scenarios. If
Mm.
you just remember this chart, you'll be able to answer the questions.
So this 100 units is a bolus dose.
Yeah.
Okay.
So you give it at various sites, no? Like I told you, 10 unit per site.
So altogether they are giving 100.
Yeah.
Okay. Okay, ma'am.
So then the other option is percutaneous sacral nerve stimulation. This is not you just need to know like briefly about it. They don't give you they don't ask you in detail about it.
Mm.
So how is it done? So
Mm.
a I'll just show you the picture. So there is a device which is put,
Mm.
which stimulates the sacral nerves S234. Okay, so skin incision is made a few inches above the coccyx and just off the midline near S3 foramina, and a smooth temporary electrode is placed.
Okay. Mm.
It involves unilateral or bilateral implantation of electrodes into the S3 S4 nerve roots.
Okay.
Correct placement is confirmed by levator, because these are responsible for the contraction of levator ani muscles and
Okay.
plantar flexion of the big toe and stimulation of sensation. So, with this, you assess whether it is correctly placed or not. And these are connected to implantable impulse generator unit, and continuous low frequency stimulation is used to modulate bladder and pelvic floor muscle.
Okay. How they are confirming with levator and a muscle?
uh, Digital, they check, no, they
Okay.
ask
Uh,
the patient to contract,
okay. Okay.
or
Okay.
they
Yeah, got it.
stimulate this device.
Working or not? Okay.
There'll be contraction of levator in eye muscle.
Okay.
So advantages, so there is a device which is placed, and it is placed to the these are the electrodes through the sacral foramina, they put. Okay.
Okay. Mm.
It stimulates these nerve fibers. Advantages, so it has only 50% success rates.
Mm.
Okay, and benefits of this persists for 3 to 5 years after implantation.
Okay.
So they might disadvantages. They might need surgical revision after this time. There can be chances of failure, and
Okay.
initially they do test stimulation,
Mm.
and only if it is successful they continue. So it may be successful because only 50% cases it is successful. So it might symptoms might improve or symptoms might not improve.
If suppose it's not working, they have to remove it.
Yeah. Okay, so this was about percutaneous sacral nerve stimulation. Then there is posterior tibial nerve stimulation.
Mm.
So in this sacral nerve stimulation, they're putting the device inside the body. In
Mm.
tibial nerve stimulation, they're not putting anything inside the body. So this is minimally invasive procedure. Is a
Okay.
form of peripheral neuromodulation which involves intermittent stimulation applied to the posterior tibial nerve
Mm.
using a needle electrode 5 to 6 centimeter above the medial malleolus. So this
Okay.
is how it is. There is this device on which like near the medial malleolus they have attached this electrode
Mm.
which give the stimulus. So they're not putting anything inside
Okay.
the body.
Okay. Mm.
Okay. So 12 weekly session, 30 minutes each are given.
But the electrode is kept inside only.
No, it is attached outside only of the
Oh,
medial
oh,
malleolus. The medial malleolus.
attached outside, just
Yeah.
lateral to the foot.
Yeah.
Okay.
Okay. So it is not invasive. Like
Okay. Mm. Then it
then,
is not at all invasive.
sorry.
It is not at all invasive. When
Yeah.
electrode is
Yeah.
attached outside. Okay.
Yeah, but it is stimulating the nerves, no? So that's why they call it minimally invasive.
Like some vibration.
Hmm.
Okay.
Okay, then augmentation cystoplasty.
Mm.
What is done in this? We use it only for the management of idiopathic detrusor overactivity to women whose condition has not responded to non-surgical management and who are willing and able to self-catheterize.
Mm.
Complications are there are common and serious complications of it. There can be bowel disturbances, metabolic acidosis, mucus production and or retention in the bladder, UTI, urinary retention, and there is also a small risk of malignancy and so because of that the patient requires a lifelong follow up. So the augmentation, it's a surgery of the bladder that they
Mm.
do.
So it has got complications. Mm.
Yeah, so it is reserved as a last resort.
Mm.
And the last option is urinary diversion, which is again a last resort where
Mm.
they divert the urine. So they create the ureter opens into ileum, so there is no urinary tract at all.
Mm.
Okay, so that is diversion. So urinary diversion should be considered for a woman with overactive bladder only when non-surgical management has failed and a botulinum toxin A, percutaneous sacral nerve stimulation, augmentation cystoplasty are not appropriate or unacceptable. And this also requires lifelong follow-up.
And can you please repeat this, ma'am? What do they do?
They create they open the ureter into the ileum.
They open the ureter into the.
Ileum.
What is that?
They divert the urinary tract. No, it is not coming, no longer there is urinary tract, so that they divert the urine from the ureter. Now with the motion the urine will pass.
Oh, along with these two.
Sensation at all.
Okay, so they are disconnecting from the bladder.
Yeah.
So the bladder is not functioning.
Yeah.
Okay. So urine is coming directly from the ureter through the colon.
Colon or ileum, mostly they
Okay.
connect to ileum. Okay, so that is diversion, they divert the urine.
Okay.
So this was all about incontinence. Any questions?
No.